All right, part 3, more to the lower GI issues. Now again, sorry about this, having to scroll down again. All right, diarrhea. Another sometimes complicating thing that we'll see. You can see it, in acute care in the office, and also in the hospital, is diarrhea, and evaluating that and coming up with a diagnosis for that. So that's basically broken down into 3 areas: acute, persistent, and chronic diarrhea. So acute, less than 14 days, persistent, 14 plus, and then chronic, 30 days or more. And that's kind of fluid depending on your symptoms. It's not an exact days, but it kind of sends you in the right direction for diagnosis and for treatment. Acute diarrhea, most cases are infectious and self-limited. And when patients have acute diarrhea and are feeling awful, it's sometimes hard to tell them, we think this is a viral thing, it's gonna ride itself out. And they're like, are you kidding me? I have to work, I have to take care of the kids, and most causes are viral. And so it's just a matter of treating them to keep them comfortable. So here you got the viral causes, and this is not everything. So there's a lot of different causes. So viral, you got your norovirus, rotavirus, adenoviruses, bacterial, Shigella, E. coli, C. diff, salmonella, and then your your protozoan things. So your crypto, your giardia, and cyclospora. And I heard there was some, there's a crypto outbreak again at one of the health clubs, correct?
Oh, gross.
I forgot which health club it was. This is recently, in the past week or so.
Awesome.
I heard about. So it's definitely out in the community. Acute, the diagnosis, again, the history, detailed history is important in it. This is pretty extensive for the acute, but we want to know about this, and this will also be used when you're doing a chronic workup as well. The characteristics of the stool, onset, frequency, volume. I'll have patients come in the office and they say, I have diarrhea. And again, you'll be like, okay, well, how often does this happen? Oh, maybe once every 2 weeks. Versus your patient who's having 5 to 10 stools a day. And then I'll ask them, well, what do you consider diarrhea? And they'll be like, well, maybe it's kind of mushy, the first thing I'll say is it watery? Is your diarrhea watery? That's what I considered diarrhea, loose or watery stool. And also your older patients who tell you they have diarrhea, but they'll say they won't go to the bathroom for days, but then they have diarrhea. I said, okay, well, did you have a solid stool first? They'll say yes. Well, you got constipation overflow. So it's really important to get an exact history on that. Do they have nighttime awakening to go to the bathroom? That's a big one when we're diagnosing inflammatory bowel disease. Urgency, incontinence. Do they have associated GI bleeding? Do they have constitutional symptoms, fever, chills? Do they have weight loss? Do they have pain? What's their occupation? Do they work in daycare? Do they work in healthcare? Were they recently in the hospital for a knee replacement, and were they on antibiotics? Are they, in the case of the other, I think my own grandmother, who I believe she had diarrhea, but she was actually taking a medication that she thought was helping the diarrhea, but actually causing worse diarrhea. So, really look into that as well. Sick contacts, travel, did they go to some big family party? Did they eat out at a buffet? And then, their other medical history. Do they have history of hyperthyroidism? Are they immunocompromised? Indications for further evaluation for acute diarrhea. So, do they have profuse watery diarrhea? Are they getting dehydrated? Are we needing IV fluids now? Or, electrolyte imbalance? Hypovolemia, bloody diarrhea, again, fevers, abdominal pain. Were they recently hospitalized? We want to know all about that, because that might send us in the direction of how we're going to treat these patients. Evaluation, physical exam, of course, blood counts, looking for electrolyte imbalance. I put these in parentheses because this is probably not going to be something you're checking with acute diarrhea. But sometimes if you feel like someone may have inflammatory bowel disease or something, maybe you want to check a C-reactive protein or a sed rate to see if they have some sort of inflammatory issue going. Stool studies, definite we're checking for, depending on the institution you work for, we have now, I think it's a GI pathogen panel, I think, for stool, and it kind of incorporates everything, bacterial, I think maybe some over and parasite, that's NOR, Pro Health now. But definitely checking for C. diff, stool cultures, checking for the bacteria. We might check for fecal leukocytes or white blood cells in the stool to see, is this are you having like an acute, is there acute, really chronic, and you're trying to rule out infection, because if there's white cells in the stool, could that be an inflammation or infection? So if the presence of fecal leukocytes is there, that might point us in the infectious, versus if it's negative, well, maybe it's something else. Over on parasites, more related to travel, daycare exposures, or community outbreak, again, like the crypto, or was it the crypto or Giardia? I'm getting it mixed up with the recent health club exposure. Norovirus, rotavirus. I would say most in the fall and the winter. Sometimes we're checking that in patients who come in, even with the hospital settings and they have a good enteritis. We might start to check viral studies, but those take like 5 days to come back. So by then you're treating them symptomatically anyway, and you're sending them out the door. And then you calling them at home, guess what? You had rotavirus. Yeah. How's your kid? Do they have diarrhea? So imaging, abdominal x-ray, I put a question mark there. Again, I think more of when I related to patients that might have constipation overflow. Are they actually constipated, and are they leaking liquid stool around their solid stool? So I might check to see how much stool volume is in there. And a CT scan, obviously, if there's severe pain. Endoscopy, not typically needed with acute diarrhea, obviously, but possibly if there's and by endoscopy I mean like colonoscopy, typically, possibly if there's a question of IBD or in an immunocompromised patient. Treatment, typically conservative, hydration, electrolyte replacement, low fiber diet. Antibiotic therapy is case dependent. In general, sometimes the patient come back from some foreign vacation. We want to avoid, I know Cipro is one of those drugs sometimes we'll treat, but if you have E. coli, put some patient on Cipro, it can cause a hemolytic uremic syndrome. I have not seen that happen, but try to be sensitive to that by giving that accurate history. C. diff infection, typically treated with metronidazole first, but there's been some resistance, obviously. So then we go to oral vancomycin. And then empiric treatment, we might consider, depending if the patient has fevers or bloody diarrhea, again, except for the case of the E. coli, dehydration if they're immunocompromised. And then typical treatment would be Cipro, fluoroquinolone, or plus or minus metronidazole. Antidiarrheals.
So if you give Cipro with the E. coli, it can cause that hemolytic.
HUS, yep. So
hemolytic, what was that?
Hemolytic uremic syndrome.
Okay.
I've heard about one case. One of our docs said it was a younger female that it happened to, and it might have been when he was training. So I haven't seen it, but we try to be careful if we think that it could be, if they could have E. coli, treat symptomatically, and hold off on antibiotics. Antidiarrheals, I put that in there if there's no suspicion for bacterial infection. That being said, we could test for viral, some other bacterial stuff, and there's other stuff out there we might not know cause it. Just be careful if they have active C. diff or some other confirmed bacterial thing. You don't want to stop them up. You can cause big problems with that. But if we're treating an acute, maybe viral illness, then we're going to use that. Antispasmodics can kind of slow down the motility of the bowel as well, and help with abdominal cramping, which is often the case. And then probiotics, plus or minus, again, we'll talk a little bit probiotics with IBS. We'll still treat with the probiotics if, trying to get that gut flora kind of regulated. But there's not real strong evidence for that out there. Chronic diagnosis, again, see the acute history, other additional considerations. We're thinking about IBD, we're thinking about post gallbladder resection, or it's called bile salt diarrhea, post-coli diarrhea. Do they have a history of pancreatic insufficiency. There's a lot chronic causes for diarrhea. Food intolerances, again, it's all across the board. Etiology, here's just the different etiologies for chronic diarrhea. We'll talk about IBS and IBD, and a little bit about celiac disease. Classifications, again, this is a little bit more in depth. I'm not expecting people to completely know this, but when we're working patients up, if we don't know what the cause of chronic is, we will do more stool studies and try to figure out what kind of diarrhea it is, osmotic diarrhea versus a secretory diarrhea, which will help us point us in the right direction. Symptoms of malabsorption from bacterial overgrowth or pancreatic insufficiency, inflammatory IBD infection, things of that nature. Evaluation, physical exam, if we're thinking about IBD, we definitely want to look in the mouth. You're looking at their skin, any associated symptoms. We have, in IBD, you can have some skin issues. Rectal exam, sometimes, I don't know that I'm doing a rectal exam, but if you feel like the patient, again, is coming in with acute on chronic issues, maybe a history of constipation, maybe you want to check one. Thyroid, hypothyroidism, hyperthyroidism cause big issues with bowels. Here's some more lab work. Here's the inflammatory markers they're talking about, more chronic. They're not specific, so they're not diagnostic, but they might help us point us the right direction. We checked for celiac sprue for patients as well. Endoscopy, depending on the scenario, EGD and or colonoscopy. Stool studies, again, which are not pleasant for patients, but if, we really need to get down to, what's going on, probably by then they're coming to us for this chronic workup. Neuroendocrine tumor workup, that's our bread and butter as well. Imaging, we might get a CT scan, we might look at the small bowel as well. Treatment, obviously treating underlying disease, infection. These are some, drugs that you can use again for chronic diarrhea. Sometimes we don't always figure out what's wrong with the patient. So what can manage their symptoms? Is it IBS? Do we need to use, are we controlling diarrhea? Are we controlling abdominal cramping or hypermotility that might cause diarrhea? So there's some different treatments there. Again, here's a little mention of the probiotics. I'm kind of a probiotic girl where I'll try it. I'd like to try it for a month or two. And sometimes patients respond to it depending on, if it's functional or not.
Is there certain probiotics that are better than others?
There are so many out there that it's hard to say. I have my favorites, and I'm sure there's some more.
What's your favorites?
What are my favorites? I wouldn't say total favorites. The bigger ones that I have gone to, which I've had luck with patients, are VSL number 3, which is more expensive. It's probably, I think on average, probiotics cost patients about $30-40 a month.
What's it called?
VSL number 3. But then again, you have, and Culturelle is a good one. Sometimes we'll use that more with patients with diarrhea. You have Florigen, Floristore. Those are more brand name ones. Patients, everyone,
every day.
Yeah. Everyone has, there's different probiotic bacteria in all of those. I haven't delved real deep into what condition works better with a probiotic. I don't know there's many studies out there. And sometimes it's more or less,
Last semester I was with an NP and a PA, and the NP didn't push it at all, and so there's not enough evidence behind it, and the PA was like, I've seen good results, and I use them. So it's okay.
There is not a lot of studying of support and evidence behind it, but I think it's worth trying if it's going to work for someone. That being said, I think about cost for patients. It's not typically covered by insurance, and so, but if I feel like it might be helpful for the patients, I had one patient with celiac disease that was very compliant with their diet, but was continued to have almost irritable bowel type symptoms, which they can. I put her on a probiotic, and she's like, oh my gosh. She's like, I feel like $100 it's night and day. Thank you. And I'm like, I don't do it. We just try, do it. But for her, whatever it was altered bacteria in the gut, and it worked for her. So I feel it's worth trying. But I usually tell the patients, if it doesn't make a difference within a month or two, then it's probably not worth the money.
So do you keep them on it long term?
For her, yeah, I would, as long as she was having.
So does it like affect the gut flora for other reasons? Like, are they?
It shouldn't have an ill effect.
Because like the PA that I worked with, he always gave it, like whenever he gave an antibiotic, he would give a probiotic with it.
Yes, and thank him for being mindful of that. It's hard because you don't always know who's gonna, C. diff obviously is a big thing that we think about with patients on antibiotics, and probiotics aren't always indicated when you start antibiotic therapy, but I don't think it can hurt. That's in my opinion.
Recommend them all the time.
Do you?
Yeah, I do recommend
I
them.
feel for personal,
But not
I feel
at the
better
same
on
time
them.
you take the antibiotic.
No, he always would do, like if your antibiotic was morning and night, then he would have him take
Yeah.
it in the afternoon. Like he said, it can't be at the same time.
And my son's fiance had C. diff at the age of 24, and she was prescribed, besides the medications, a probiotic.
Yeah,
And she still got C. diff.
No, while she was being treated.
right.
Oh.
She was
Still-
given, told to take it and to take them now.
I would say, not
Consistently.
everyone, but if patients are diagnosed with C. diff, we are putting them on a probiotic,
Yeah.
and then I usually tell them to continue the therapy with a probiotic at least 2 to 4 weeks after they stop their antibiotic
Yeah.
treatment.
Yeah.
And that's what she was told, but I told her take one a day forever.
That being said,
Yeah.
there isn't a whole lot of
So I've
And I
heard
think
some people
evidence-
take
Well,
like.
one of the problems with probiotics is there's no money to be made. They're already available. A company is not going to invest millions to do studies when they're not going to make anything.
It's really hard because there's so many different.
Yes.
There's so many generics, and people are going out to their, and they'll come in and they'll be like, I'm on a probiotic. I'm like, okay, which one?
Yeah.
And it might be something that's just like
Not good
really
either.
effective, and you feel kind of bad. And I don't want to throw all these expensive things at
Correct.
them either, but I just want to say, hey, just so you know, if you don't feel like it's really working, then it's
Don't
probably
take
not
it.
worth staying on it. But
So
maybe you want
what
to try.
about yogurt?
You can do, Yoplait or kefir, or you can try, there's other things that have it in it.
Natural cultures.
Yeah, you can, I would say that I'll use that with patients, maybe with irritable bowel, or we'll try things like that if they want to be more holistic about things and not really want to be on a med per se. But I don't, or Activia, Activia Yoplait or kefir. But I don't know that I haven't heard that patients, it makes like a huge
No?
difference. But it
I
may
was
work.
Doesn't
My mom, she was doing like Activia a day, but I honestly, I don't know there's enough active cultures in there to make a huge difference. But if it's like mild symptoms, might be worth it. Celiac sprue, celiac disease, touching on that, is an autoimmune disorder characterized by intolerance to gluten. So, and that's protein found in wheat, rye, and barley. It's associated with inflammation of the small bowel mucosa, which results in atrophy of that small bowel villi. Celiac disease affects approximately 1% of the population worldwide. Initially found to occur in patients of European ancestry, but that's kind of, and it's increasing in frequency in different geographical areas. Despite awareness of celiac disease, patients are still, a lot of patients are still undiagnosed because they might not have they might be asymptomatic. That's another one that you can come in and have a patient with anemia.
Seems like more and more people have celiac disease nowadays.
Yeah, my son is, he's in full-blown celiac, but he has biopsies. His biopsies were indicative of maybe like an early celiac, so we treat him with a gluten-free diet. Clinical manifestations, sorry about my itchy trigger finger there. Symptoms, and typical symptoms, you might hear diarrhea, steatorrhea, flatulence, or abdominal pain and bloating. Those are major ones. My aunt has celiac disease. She actually was constipated with her symptoms. Non-GI symptoms, failure to thrive in children, weight loss, anemia. We might have a patient with no other risk factor for anemia, and they come in with iron deficiency, anemia, and celiac disease should definitely be entertained. Vitamin deficiency, arthritis, and bone disease. Diagnosis can be made with serologic testing. And I put the asterisk here because you want the patients to be on a regular diet when they're tested for antibodies. If they start a gluten-free diet and a month later they come in for labs, if their antibody count was low, it might normalize if they're doing gluten-free, a strict one. So usually we'll want patients come in eating a regular diet. Pretty much when I see patients in the office, I'm getting a tissue transglutaminase antibody, and then also ordering a total serum IgA antibody. And the reason why we do this is if they are IgA deficient, obviously these antibodies are going to be falsely negative.
Mm-hmm.
So other things that you can do is labs you can do is the deaminated gliadin peptides. I will say this, if they do have an IgA deficiency, you can order tissue transglutaminase IgG. And you can do this, a lot of primaries will start doing testing in the office. And it's helpful for us, they come in, they have this done already. And there's some other antibodies, but some of these have lower accuracy. So basically I'm testing these two when they come in. Gold standard is to do an EGD, endoscopy, and biopsies of the small bowel. For example, my son in my case, his symptoms were mainly, I don't want to say failure to thrive, but he was very thin and he had diarrhea. And so he had gone to the allergist and they did tissue transglutaminase antibodies, which was positive. So we went in for the EGD. His small bowel actually looked good. So there was no small bowel damage, but when they biopsied the small bowel, he had leukocytes, white blood cells in the small bowel, which is early phase of celiac. We call it celiac, like a gluten sensitivity. And so put him back on a regular diet, because to put a child on a gluten-free diet is challenging. Any patient really. I thought, you know what, if I'm gonna do this, and I'm gonna strict gluten-free diet the rest of his life, I want to know. So he went back on a regular diet for about a year. Wasn't eating as much, went back, and then his biopsies were kind of worse, more white blood cells, so he's been on a gluten-free diet indefinitely. So here, celiac sprue, here's a normal looking small bowel. You can see defined villi here, and in the pathology you can definitely see the difference. Here, villi definitely more blunted, and so this is classic sign of celiac. Who to test? So those with GI symptoms suspicious for celiac disease, or any unexplained iron deficiency, and patients that are more at risk for type 1 diabetics, Down syndrome, patients with Down syndrome, and first degree relatives of individuals with celiac disease. There's some difference in opinion about testing those relatives if they're symptomatic versus asymptomatic. Definitely if they're symptomatic, I would do it. Asymptomatic, plus or minus. It's not required, but maybe you want to consider that. My whole family, we were tested, and none of us were positive. So, management, strict, lifelong adherence to a strict gluten-free diet. There's no other treatment at this point for that, and that's tough. So I often refer to patients to a dietitian to help them along. We monitor for nutritional deficiencies. The ones in red are the ones that I actually look at on a regular basis. So vitamin D, B12, folic acid, ferritin, and iron. These other things I'm not testing regularly, and I feel like I'm wasting a little bit of money with doing that on a regular basis. Long-term follow-up, it depends on the patient and their compliance. You can, if you are suspecting they have, they're not completely compliant with their diet, then we check tissue transglutaminase. We definitely do bone density. They have, nutritional deficiencies, vitamin D and such. So we're checking DEXA, and then pneumococcal vaccines. So additional conditions that can happen with celiac. You can get IBS, lactose intolerance, bacterial overgrowth. So sometimes we have to treat beyond that. IBD. Chronic autoimmune disease that causes intestinal inflammation. It's compromised of two disorders, both ulcerative colitis and Crohn's disease. And then both disorders have distinct and overlapping pathologic and clinical characteristics. Here's a picture of ulcerative colitis on the left, and then Crohn's disease with patches of skip type lesions. IBD, Here's the incidence for IBD. Typical onset is age 15 to 40. However, we do diagnose patients later in life. Often these patients come in with chronic symptoms, so they've been dealing with for years. Males and females are equally effective. Pathophys, the thing that I want to point out, the difference between IBD, with UC, and Crohn's is ulcerative colitis is limited to inflammation is combined to the mucosa of the colon. And then inflammation extends proximally in a continuous pattern. And then Crohn's disease, it spreads, the process can begin in the submucosa of the intestine and gradually spreads to involve the mucosa and serosa, so all layers of the colon. And then typical lesions are granulomatous with inflamed tissue started by scar tissue, described as that cobblestone appearance, just like here. Looks like kind of like cobblestones. Manifestations with UC, diarrhea is the big one, hematochezia, blood in the stool, incontinence, urgency, and then abdominal pain, other symptoms, fever, fatigue, weight loss, anemia. Some have multiple extraintestinal manifestations as well. I'll have you read those. Crohn's disease, fatigue, weight loss, fever. You have diarrhea. Not as much in the way of gross hematochezia like you would find in ulcerative colitis, so that's another major thing that we probably would want you to keep in mind with diagnosing or monitoring your patients. Abdominal pain also varies on location. Crohn's disease, clinical manifestations, you can get perianal disease, abscess, fistula formation, malabsorption. The thing about Crohn's disease also to keep in mind is that it can involve anywhere from the mouth to the anus, where ulcerative colitis is limited to the colon and maybe the end of the terminal ileum. Manifestations of Crohn's, you have the extraintestinal manifestations as well. Again, the skin, arthritis, joint aches, things of that nature. We watch for osteoporosis and vitamin deficiency. Differentials for that are listed here. Diagnosis by history, physical exam, very important. Labs, again, checking for anemia, checking electrolyte imbalance, and here's your inflammatory markers. More than not, we're doing colonoscopies to diagnose these patients, so sometimes we won't do this right off the bat unless we don't know exactly what's going on. We'll probably test for stool studies as well to make sure they don't have some underlying infection. And then there's special testing if we're having difficulty diagnosing a patient and between Crohn's and UC, we might get what's called Prometheus testing to help us diagnose that so we can treat them.
What is that?
But that's, by then they're seeing us for that.
What is Prometheus?
It's a testing that helps, it's a specialized lab that helps us diagnose and differentiate between Crohn's disease and colitis.
Oh, okay.
Because sometimes it doesn't look, and I'm not an expert on Prometheus testing, but sometimes it's very difficult based on symptoms and what we're seeing in the colon and what inflammation looks like, and sometimes it helps us with determining where we need to go with treatment. Endoscopy, colon with biopsies for sure, EGD if there's upper GI symptoms. I put this in here, but you have to be very careful. If a patient has Crohn's disease and strictures in the small bowel, you certainly want to be sending a capsule down there. But sometimes this is considered. Imaging, we might do an upper GI small bowel follow-through to look for Crohn's. CT, MRI, again, we're looking for, inflammation, strictures, and then baryomonas at times. Treatments, the big thing, I'm not going to get deep into treatment, but choice of therapy depends on anatomical location of the disease, the severity of the disease, and the goal of therapy, whether we're trying to induce this patient or maintain remission. Treatment, there's topical anti-inflammatories we can use. There's oral medications, oral anti-inflammatories. You got your good old glucocorticoids, your prednisone. We do have non-systemic glucocorticoids like budesonide we'll use, and then immunologic therapy. You have your azathioprine, your 6-MP, methotrexate, and as well as biologic therapy. There is a new drug, Stelara, that was just FDA approved in September. Not used it yet, and the 2 doctors that I talked to about it have not used it yet. So,
Do people have to go through, like, patients with RA? Do they have to fail certain treatments before they can move into some of the wonderful new
Sure.
biological? Just out of curiosity.
Again, it's based on severity of symptoms.
Okay.
You know, where we might do a step up versus step down approach with
Okay.
therapy again. It patient dependent. Also, sadly enough, insurance.
Yeah, because
is a
those are
big
very
factor.
expensive.
And you know, maybe they won't cover. Humira is usually covered. That's because that's been around forever. It's used with RA as well, and Remicade. If we want to try other treatments, you know, if we want to start using like Entyvio and things of that nature, then that's when we run into problems. Did they fail a traditional anti-TNF therapy first? Then they might, okay something different. But so antibiotics sometimes we'll use if we think there might be some underlying infectious process, and then surgery is our last resort. But if they're severe enough, sometimes we have to do small bowel resections or colectomies, unfortunately. IBD routine health maintenance, immunizations are important regardless of immunosuppression. We recommend yearly fluid pneumococcal vaccines. Live vaccines are contraindicated while patients on immunosuppressants. We're asking that those be administered 4 to 12 weeks prior to treatment, but often enough when they come in, they have to be treated then. So that becomes an issue. We can't wait 4 to 12 weeks when a patient's, in a complete flare, wait for them to get immunosuppressants. But if we anticipate we might put them on Humira or something more than an oral agent, then maybe, we're definitely making sure that that this is completed. And then they need Hep B screening before anti-TNF therapy like Humira and Remicade. Health maintenance, regular screening, typical exam. Once they've had IBD for 8 to 10 years, they usually need to come in for a colonoscopy every 1 to 2 years. Pap smears in women who are immunosuppressed, even in our old ages. I talked to a GYN doc about that, and then talked to our GI docs as well. They're on immunosuppressant. We're supposed to still do GYN exams. Skin exams, if they're on azathioprine, 6-MP, they're at increased risk for non-melanoma skin cancers. Health screening, these are some of the other things that we need to do. I'll let you read about those. And then smoking cessation, NSAID avoidance. Even though it's anti-inflammatory, there's a process that can make the inflammation work worse with IBD. And then we, watch blood counts and vitamins. IBS, how are we doing on time here? All right.
I know it's going to be a little.
It's going to be a little over. Sorry about that. GI syndrome characterized by chronic abdominal pain and altered bowel habits. It's a functional disorder. Affects about 10 to 15% of the population. We'll look over these other demographics. I would say it is more of a diagnosis of exclusion, so we're ruling out other organic issues like IBD and other colon problems, and ruling out other major diseases. Possible causes for IBS are altered GI motility, inflammation, post-infectious IBS, bacterial overgrowth, food sensitivities, and psychosocial issues. Clinical manifestations, chronic abdominal pain, kind of usually described as crampy, it, comes and goes. Another big one here, relief of flatus and defecation. I usually ask, that's one question I ask most patients if I'm thinking IBS. Even if they have, even if they say, well, no, it doesn't relieve it, it doesn't rule out IBS, but it's a good indicator. Different patterns to IBS, IBS-D, IBS-C, and mixed IBS, and then there are other symptoms as well. Well, you'll often get patients say, I'm passing like a white mucus in their stool. And then you can also get upper GI symptoms with IBS as well. Diagnostic criteria is more based on, there's different ones. This is a pretty common one, the Rome criteria, usually based on abdominal pain and altered defecation. but I don't sit down with my patients and look for exact criteria. IBS, alarm, just keep in mind alarm feature is not indicative of IBS. So I talk about red flag symptoms. So fever, chills, nausea, vomiting, blood in the stool, weight loss. Those are things that tweak me and are not indicative of IBS. Other things, thinking about it, nocturnal pain, abdominal pain, rectal bleeding, all of that. Weight loss, any of this we want to, if any of this is occurring, then it's most likely not IBS. Diagnosis, labs sometimes, you put in there, we're ruling out other things. Stool studies, I'm ruling out infection. We don't typically do hydrogen breath testing in our practice. I will test for celiac disease. I may get abdominal imaging, but if this is a really, really chronic problem, I'm pretty sensitive to not radiating patients more than I have to. And then referral, indication for referral, any alarm features, or if you've done some work up in the office and you think I need help, because it can be difficult to deal and take care of patients with IBS. It's a syndrome. It comes and goes, it flares, and it can be very problematic for these patients. Other things we might consider colonoscopy and EGD are usually done. So, management, emphasize to the patients, go over their history, tell them what they've done to work things out, tell them what is normal, what's been ruled out, and empathize with them, because it is, it's debilitating to some patients if it's severe enough. It alters their daily life, and so you need to empathize with these people and let them know that this is what we've done so far, and we realize that you do have symptoms and that those symptoms are going to come and go, and sometimes you could feel great for months and then sometimes feel really poorly for months, and it's a matter of controlling symptoms. Lifestyle modifications, sleep, stress, activity, dietary modification is huge. Food journals, try to get them to kind of think about the food they're eating. Are they eating a really high carb diet? That causes a lot of bloating, a lot of gas. Your colon feeds off those sugars. Sometimes we'll ask patients to try, work with a dietitian, do a FODMAP diet. I won't go into great deal with that. And I usually refer to a registered dietitian for that. But gluten-free diet as well. We've had some good results for that. Fiber, if there's constipation, but again, keep in mind, fiber can cause bloating. So start low and go slow. And then sometimes allergy testing. And then psychological interventions, always think about. Here's treatment to patients depending on what their predominant symptom is by constipation, diarrhea, pain, or bloating. So there's some recommendations in there for all of that. Again, with the abdominal pain, antidepressants are listed in there. That we just had to review a little bit of that in one of our journals. I personally, because I don't follow these patients on a regular basis, I hesitate for myself to put them on an SSRI if I'm not going to be the one to follow up. Some of our docs will. I often will refer to, and send a note to the primary. Diverticular disease, I would say, I won't touch on this, but really quickly. It's pretty common in the Western. It's usually, related to, more often than not, the lack and poor diets that we have here in the U.S. But some of the complications we see often are bleeding and diverticulitis. So here's a picture of the colon with the ticks in it, if you've never seen that before. I'm going to rush through the patho here. You can go through that. But possible risk factors and things we treat with patients is, low dietary fiber. So we tell them, we encourage fiber in their diet. Things that may cause it: high-fat diet, red meat. There used to be there is a misnomer of this nuts and seeds.
Yeah.
It's not necessarily a cause of diverticulitis, and they don't recommend that we avoid those anymore, unless I tell patients, if you have problems with corn or popcorn and it causes some discomfort with your tics, don't eat it. But fiber is good for diverticulosis. Complications, I will skip over those and due to time.
You don't have to.
You don't? Are you sure? Okay.
They don't know.
Okay. So some complications: diverticular bleeding, diverticulitis. I will go over that because that can be treated as an outpatient. and diverticular colitis. Presentation is, pain. Usually it's in diverticulosis is usually limited to the left lower quadrant, but it can occur, it's more predominantly in the sigmoid colon on the left, but it can occur all over. Diverticulitis we're diagnosing with elevated white blood count. We may or may not get CT abdominal imaging. If I see patients in the office and all their symptoms and signs point to diverticulitis, we might not always get a CT scan. We might treat them empirically with ciproflagyl. Differentials for diverticulitis are here. Management, inpatient versus outpatient. So antimicrobial treatment for that, we usually want to cover for both gram-negative and anaerobic pathogens. So treatment course about 7 to 10 days. Typically we're putting on patients on a fluoroquinolone plus a metronidazole. These are other options as well depending on allergy. And then, you definitely can treat a patient, as an outpatient but we'll go over some red flag symptoms that might require them to have inpatient treatment. Surgery, obviously, in recurrent episodes or failed management. And if you get a patient that's come in, usually start thinking about surgical intervention after maybe a second to third episode. And again, if we don't have CT or imaging documentation and they have diverticulosis throughout their entire colon, we don't always know exactly where it's coming from, and it makes surgical resection of an area difficult. And I'm
They won't have a clue that this
Yeah.
is. You gotta cover it.
Yeah, okay. So if the patients are starting to have issues and you treat them as an outpatient and they come in with persistent, abdominal pain again, we might then get imaging if we haven't done it already. We might put them on an extended course of antibiotics or change their antibiotics. And if their pain isn't controlled and they're still having fevers and issues, and then we're sending them to the hospital. So, okay, constipation. Huge problem. Huge problem in the US, I'm sure, common in the Western society.
And
the prevalence is
primary
about
care.
15%, but again, it's pretty subjective sometimes, and depending on the history. And it depends on certain diagnostic criteria too, which there's no specific diagnostic criteria for constipation. It occurs throughout the lifespan, including, children and elderly and everywhere in between. And here again, characterized, there's no definitive characterization, but how many stools are they having? A normal for one patient could be different for another. Some patients don't go but once every couple of days. But if that's the norm for them, that's okay, if they're not symptomatic. If they're having a lot of issues, that might not be enough for them. So history important there. Consistently, they're reporting hard or small pebble-like stools, difficult passage or straining, and incomplete emptying. Sometimes they'll be like, well, I go like 3 or 4 times a day. Then I'm starting to think, are you emptying enough when you're going? Are you, passing small amounts? Are you really constipated? Even though you say you're going 3 or 4 times a day, are you emptying? And then are patients impacted? And then just a picture of abdominal x-ray with, colon full of stool. Causes, there's idiopathic, sometimes we don't often know. You might have someone with a normal colon transit, but they still run on the constipated side of things. Pelvic floor dysfunction, I would say, is a big one that I see with women in the clinic. And so that is definitely in the workup. But we're doing other things first before we sometimes are ruling out pelvic floor issues. Secondary causes for it, neurologic issues, obstructing lesions. Of course, we're wanting a colonoscopy. Sometimes psychiatric disorders, IBS, medications are another big one. Doing a medical history is a big one. Obviously, some of the bigger ones, iron, opiates, but some antihypertensives and some other agents cause issues as well. Causes, again, secondary causes all over the board. Electrolyte imbalance, hypothyroidism, pregnancy, obviously a big one, lack of either diet, sedentary lifestyle, and then, just even taking as we get older. Even taking a plane ride and going to a different
Yes.
state and being out of whack and not in your home can throw you over the edge. Diagnosis, the nature of symptoms, the duration, again, history important. I always say history is important. Misconceptions of constipation, and I put that in there saying, what do patients think that constipation means, or what is constipated for them? And so, sometimes, like I said, it's just delving into their bowel habits and their bowel patterns. Secondary causes, obviously meds we're looking at. Are there any other associated symptoms? Pain, nausea, vomiting, all that, rectal bleeding. Physical exam, not always helpful. Sometimes if they do have pain, a rectal exam, especially in the elderly, again, diagnosis labs we might consider depending on associated symptoms here. Endoscopy, sometimes, we might do a colonoscopy depending on the patient's age and underlying issues, how, even in the young people though, if it's chronic already and their issues, we'll still do a baseline, just to make sure nothing else is going on. And then obviously multiple studies that you could do. Sometimes I will get an x-ray on a patient if they're, I try not to. If it sounds like by diagnosis we can just try something empirically with a gentle laxative.
I know where I practice, there's a big push for ordering plain film x-rays for constipation, and you do a digital exam, and if you can feel hard stool.
That being said though, you're not always impacted.
Yeah.
You can only go so far.
Correct.
And sometimes will be more blocked on the right. So it's very rare for me to order an x-ray in the office.
Yeah.
But if I'm on the fence and a patient's very anxious.
Correct.
And
you
worried
can show them,
about,
look at all that poop.
right, and very anxious and a lot of pain, it can help them kind of relax because they're thinking they want a CT scan is what they want sometimes. And I'm like, okay, why don't we think about checking it, abdominal x-ray here. Let's take a look. And that sometimes helps. Yeah. Motility is an issue. And so sometimes we'll check and send patients for other studies. I would say sometimes we'll do SITS marker testing where they have those little markers that they go through the colon. They watch it go through by x-ray to see how long it takes. An anorectal manometry, we start thinking about pelvic floor dysfunction. Treatment, dietary fiber is key. Again, start low and go slow, because if they start banging out, huge salads for multiple meals, they're going to be bloated and uncomfortable and unhappy with you. And when you increase dietary fiber, make sure they're drinking plenty of water, because dietary fiber can have the opposite effect too, and bulk you up and block you up more. Exercise, adequate hydration. Here are the medications that we sometimes use, depending on the type of agent that you're thinking you want to use for a patient. This is, Metamucil, Citrusol. Stool softeners are falling out of favor. As of late, I would say we're using more in the way, and depending on the patient, your polyethylene glycol, bulk of magnesia. You can use stimulant laxatives. You can use a combination of things. Other Linzess and Amitiza, I'm using these with really, really chronic constipation patients that have pain and also have not responded to other treatments, and they have to be pretty severe because it's a prescription medication, and cost is an issue, and we need to always try other agents before we're going right to these drugs here. Biofeedback therapy and surgical resection is rare. Hemorrhoids, last but not least, hemorrhoids. But this is something that people will come into you like gangbusters with rectal bleeding. And so approximately 5% of the population visit their healthcare providers for hemorrhoids or rectal bleeding. And they're freaked out about cancer and colorectal cancer. Hemorrhoids can occur at any age, but increase with peak around 45 to 65. And talking about the anatomy and on how they form here. Here's your anatomy here, the rectum and the anus. Pathophys, which I will talk about. The only thing I want to point out here is external hemorrhoids. Just keep in mind that they're covered by these epithelium, which can have a lot of pain receptors. So people will be like, well, can't I come into you and can't you ban my hemorrhoids, and I said, well, the internal ones we can, but not the external. And we've done this too, if patients sedate, we put hemorrhoids anywhere below that dentate line, which is in here, they will want to fly off the cart. And so patients, if they have external hemorrhoids, those need to be surgically removed. Internal hemorrhoids, the banding, they don't have those pain receptors there, so we're able to slip little rubber bands on them when they have their colonoscopy or flexible sigmoidoscopy. Causes for that: low dietary fiber, age, constipation, multiple different causes. Presentation, sometimes patients are asymptomatic. Obviously the rectal bleeding, they'll come in with, passing bright red blood. Okay, are they passing copious amounts and the toilet is flooded with blood? Sometimes yes, with hemorrhoids. Or is it just, are they wiping and they see some blood streaks on the tissue? So history important there. Pain, obviously thrombosed hemorrhoids, we usually have to incise those. And that's quite uncomfortable for anyone who's ever had one. They might complain of pruritus and fecal soiling. Diagnosis, patients typically report painless rectal bleeding. If they start to complain of pain and other issues, then we might need to start thinking about other interventions, and maybe doing a Flexid or an anoscopy exam, or I usually don't do anoscopy exams. I'll definitely do a rectal exam in the office. Anoscopy, depending on their comfort level, and it's not still always easy because you get that anoscope in there and they're uncomfortable, and you might not. I use a clear one to try to help, but you can't always see everything. Physical exam, obviously digital rectal exam, anoscopic exam, and then sometimes we'll be sending our patients for Flexig or colon. Classifications for hemorrhoids, grade 1 through 4. You can read that. Treatment: sitz baths, fiber, analgesics, hydrocortisone, hemorrhoid banding, surgical excision, and then when to refer to us. Persistent overt GI bleeding, heme positive stool. Heme positive stool, if you're testing, again, you do the card test, that could be blood from anywhere in the colon. And if you do have significant hemorrhoids and you're sticking your finger up there, you cause a little bleeding, that test will be positive. And then I put this in here because in the literature it said that heme positive stool is not affected by hemorrhoids, but it can. Constitutional symptoms, are they having any of those? Anemia, stool weight loss, family history of colon polyps. One lady I just want to share with you, just this big learning thing for me. A younger lady in her 40s came in. She had just had her screening colonoscopy 2 years ago. She had a history of hemorrhoids, have had them banded, came in with rectal bleeding and pain again, and all some signs seem to be probably hemorrhoidal again. So we were treating her conservatively because she just had that colonoscopy 2 years ago, and she was still having symptoms. So we were kind of emailing back and forth with the doctor. We finally got to the point where we were treating her for anal fissures and hemorrhoids for what she had, but it wasn't getting better. So we decided to do the Flexig. At one point, she ended up going into the hospital and had like a CT for pelvis, and she ended up having anal cancer. And I say this only because it's, for me, everything we did was pretty much textbook. We went by what she's had done, her history, a recent colon, her age. It wasn't something we were ignoring. We were trying to kind of progressively do that. But that being said, in the back of your mind, you're not getting better. There's concern. You're still having discomfort. And she did end up having, rectal cancer. And at the time, too, it was found out that she might have had a viral issue, too. I think she had contracted something from her husband. So definitely, while we want to put patients at ease with rectal bleeding at times, and it more than not, it might be something like a hemorrhoid. It's just if they're not getting better, then we need to keep working at it. So she ended up having surgery. Colon cancer screening. Colon cancer, second most diagnosed cancer in women, third in men. Occurrence is uncommon before age 40, but they're starting to see a rise in incidence of that. About 90% of the cases occur after age 50. So that's where we got that age 50 for colon screening. Average risk for patients is about 5% developing colon cancer. There's about 20% higher incidence in African Americans than in Caucasians, so they start their screening typically age 45. And then removal of pre-malignant adenomas is the key. Risk factors are all listed here. Family history is a big one. And then screening tests, sometimes, yes, sometimes if patients don't want to go through colonoscopy, we might entertain them and try to support our recommendations by testing for stool for blood. There's a test called Cologuard testing, testing for fecal, it's testing DNA, and it's pretty good with patients, especially if they're not good candidates for endoscopy. It might help us, point us in that direction, or they just refuse, but they want to know, and so that is an option. Obviously, we're doing flex SIGs. The goal is to get a full colonoscopy in a patient, though. And honestly, even though this is the shorter exam, the sigmoid colon is the hardest, probably the most difficult part to get through. So if you're going to do it, go big or go home. Do the colonoscopy. But we might check a flex SIG if they're having issues, again, like with rectal bleeding and had a colon within the last couple of years. Imaging, again, we can do a CT colonography for a quote-unquote virtual colonoscopy, but you still have to bowel prep for that. And if you have polyps, you got to come in and get them removed. So it might kind of give you a little peace of mind and hold off if nothing is showing. But if you do have something, then you got to come back in for the traditional colon. Guidelines vary about between task force. It's preferred in general for screening prevention, typical age, again, age 50, and then earlier for African Americans, and then typical colonoscopy recommendations every 10 years for patients of average risk. That changes depending on history, previous polyps removed and such. And again, age 75 is somewhat of a cutoff, patient dependent. Guidelines here again for follow-up for polyps if you have a personal history that you need to come in earlier, and then obviously more frequent maintenance for inflammatory bowel disease. And then here's some lists of GI societies that we refer to, bibliography, and that is it. So thank you for hanging in there with me, and wish everyone good luck in finishing up the semester.
We gotta pull that up.